and her name is Lakeitha Anderson. As Senior Director of Government Affairs for Legislative Outreach and Advocacy at Eli Lilly, Lakeitha leverages extensive experience in government relations to advance key objectives across public and private sectors. With a proven track record in developing effective advocacy strategies, building diverse coalitions, and fostering strong relationships with policymakers and corporate leaders, she is committed to promoting diversity and inclusion and creating opportunities for the underrepresented communities. Her mission is to shape and influence policy to benefit society and improve healthcare outcomes.
Thank you, thank you. Now, I know I am not a famous movie star, but I think you guys can give me a bigger clap than that. Thank you, thank you, thank you. It's a privilege to be here and to moderate this panel. I am new into the pharmaceutical world, but I am a daughter of a former surgical nurse, as we call her, Nurse Betty. That's my mom. When the previous person spoke about her mother as a physician, I started to think about, my mom's not a physician, but she was a nurse and a very involved nurse. So I know a lot of things about nursing. I did not go into the field, but here I am. So I'm going to welcome the panelists. There's me. That's cool. Welcome the panelists for this group. First of all, we have Dr. Pierre Theodore. So Dr. Theodore is based in South San Francisco, serves as the Executive Director of Health Impact and Patient Inclusion at Roche Genentech, addressing systemic availability and accessibility barriers to novel pharmaceutical technologies. A member of the teaching faculty of Stanford University, Pierre is a board-certified cardiothoracic surgeon and has held a range of leadership roles in industry, global public health focus on health disparities in care. And it's interesting about that word. I just bragged to him that I knew what it was because of my mother, and then I get up here and cannot pronounce it. So anyway, so next we have Dr. Nancy Childs-Schaefer. Dr. Schaefer previously served as a technical director in the Centers for Medicare and Medicaid Services Office of Minority Health in the Data Analytics and Research Group. In this role, she worked across CMS and with other agencies to develop, strategize, and implement initiatives to improve health equity data collection and analysis. Nancy I'm sorry. Come on now. Just give me a little bit. I'm sorry. She earned her BS in biological science from UMBC in 2009. Subsequently, she earned her MS in epidemiology and PhD in gerontology from the University of Maryland, Baltimore in 2014. Dr. Childs-Schaefer completed a postdoctoral fellowship at the National Institute of Aging, National Institute of Health. Her research interests include changes in body composition, physical performance with age, and health disparities. Throughout her career, Dr. Childs-Schaefer has received multiple distinguished awards for health disparities and health equity research. Give her another clap. And we have a third panelist, Dr. Herb Conaway. He's a member of Congress. He's not here yet. I'm going to go ahead. Okay, he's here. Okay, we're going to give him a second to come up so I can give him a proper introduction. It's interesting. I just saw Dr. Conaway last night at the Democratic Club for dinner. So I told him I'd be waiting for him, and here we are waiting for him. So I'm going to go ahead and talk. So Dr. Herb Conaway, a proud lifelong resident of Burlington County, is the son of a teacher and a nurse. From an early age, he was inspired by his parents' dedication to service and his community, which shaped his desire to give back. After graduating from public high school, Dr. Conaway pursued his passion for medicine, earning an undergraduate degree from Princeton University, a medical degree from Jefferson Medical College, and a law degree from Rutgers Law School in Camden. So he's had a lot of schooling, which is perfect. Dr. Conaway began his career by serving in the U.S. Air Force, where he rose to the rank of captain in the medical corps at McGuire Air Force Base. During his 4 years of service, he worked as a general medical officer and advanced to assistant director of the primary care clinic. After completing his internal medicine residency, Dr. Conaway practiced in primary settings before transitioning to academia. He became a clinical professor at an inner city community hospital, mentoring and teaching the next generation of physicians. For 25 years, Dr. Conaway served the residents of New Jersey's 7th legislative district as an assemblyman. That's when I met him. In the New Jersey legislature, he chaired the Health Committee and served on the Budget Committee and the Military and Veterans Affairs Committee. Dr. Conaway played a pivotal role in advancing significant health legislation, sponsoring New Jersey's school funding formula, improving fiscal accountability with school districts, integrated technology into core curriculum standards, and modernizing public school nutritional policies. He championed legislation addressing environmental protection, property tax relief, veteran services, and public safety. As a member of the House of Representatives, Dr. Conaway will continue to advocate for an economy that benefits the families of New Jersey's 3rd Congressional District. He is committed to protecting access to health care, ensuring environmental protection, and supporting our service members and their families while bolstering our national security. So that is That's Dr. Conaway's background. I'm going to go ahead and read that, so when he's here, we just can welcome in. Anyway, so should we start? Okay. So it's you two. Okay, I'm going to come sit next to you now.
It's like we're the warm-up act. You see.
Yeah, the one right, I know. Okay, so we're talking about the need for health care in people of color, and the title is Unequal Weight, Metabolic Disorders and Chronic Disease Disparities in Black America. That's a heavy, heavy topic, which is very much needed. So I'll ask you the first question. So could you explain, I'll go to you, Dr. Pierre, could you explain the current prevalence of metabolic disorders, particularly obesity, in Black communities, and how this compares to other racial groups?
Sure, absolutely. Latifah, thanks very much for having us here today. And I think sometimes if you start off with just statistics around prevalence and incidence and stuff like that, it has a little bit of an academic feel. It doesn't really hit. You really have to think about the impact of metabolic disorders on the lives of patients and on the communities in which these patients live. So rather than looking at it, strictly speaking, as a question of incidence, I think about the number of lives that have been lost. And one of my colleagues was at Yale University a few years ago, and he looked at all of the deaths across the Black population, compared it to the general population by various racial groups, and he looked at the number of excess deaths from the year 2020 to 2022, from 2020 back to 2000, so 20 years total. And when he did so, he noticed about 1.6 million additional deaths in the Black population. And that's a number that's a little hard to wrap one's mind around, that degree of loss, that's excess mortality in a population. Now, how does this relate to metabolic disease? Well, the majority of those lives lost were due to cardiovascular phenomena, myocardial infarction or heart attack and stroke and peripheral vascular disease and the like. And the point being is that metabolic disease is an important critical driver of the risk of cardiac disease and of stroke. And so in many ways, what we're talking about right now is not so much just purely a question of weight loss per se, but it is changing the risk of these major adverse cardiac events that lead to death and are part of that 1.6 million additional lives over just 20 years endured by the Black community.
Okay. Dr. Shaver, can you answer that?
Yes, if I can add to that as well, trying not to lean too heavy in the numbers because that's my jam. But really what's striking is that these differences occur so young in age. So really, if we think about our focus on obesity and the long-term effects that were just described in terms of the impact, it starts in childhood and adolescence. So even in teens, we see racial differences in obesity, particularly in Black girls who have a greater prevalence of obesity than their peers. Black males do generally comparable until they get to adulthood. But what's happening with our young girls? So knowing what the long-term implications are of these metabolic disorders, it's really striking that it's starting so young in age when we think about how much that compounds over time to lead to increased morbidity and mortality.
That's a great segue, because I have a question about that. Because you're right, we see a lot of overweight or metabolic issues in younger adults. And I wonder, as my questions went away here, I wonder, how do non-medical factors contribute to the higher rates of metabolic disorders in Black communities? What other than, and I want to simplify this question, what other than just eating a lot happens? Because I think that's one of the misconceptions of it is eating. And it is eating, but there's some other factors too. Can you just talk about that?
Sure, absolutely. And I neglected first to say, I need to state that all of my comments today are solely that of myself. I'm not representing any other entity today. But some of the factors that come to mind, top of mind, are stress. So chronic stress has a great impact in terms of our health, and that can impact weight as well. So stress can increase cortisol levels, and those hormone reactions can increase weight and make it harder to lose weight. We all know that our community, the Black community in America in particular, is more prone to stress due to the environmental factors, the societal factors that we have faced that generationally, and that compounds and certainly plays a role in terms of risk for metabolic disorders. Additionally, we think of food insecurity. So if you live in a food desert, it's great to talk to me about how many vegetables I should eat and eat organic and free-range chickens. Where am I getting that? I'm not getting that, at the bodega. I'm not getting that at my corner store, behind locked screens. So we need to think about these things. And when we think about our solutions, what are we actually solving? What are the roots of the problem beyond just the medical components? And I'll add additionally to physical fitness. So there's a big emphasis right now in terms of what we individually can do to make ourselves healthy. Well, if I don't live in an area that's walkable, whether for safety reasons or it's a heavy metropolitan area where I can't go for a mile walk easily, then it's a little bit harder for me to have access to physical activity compared to someone else that can go for a mile walk in the neighborhood or has the funding to have a gym membership. So it's important, again, when we think about the solutions, what are the factors that are within individuals' control? There's a lot that's not in their control as well, depending upon what their circumstances are. And I think particularly now, knowing how much there's going to be an increase in the gaps that already exist in terms of social funding and supports, this needs to be a pivotal part of the conversation because more folks are going to get lost in those gaps.
Yeah, that's really great points. I just wanted to add on top of that just taking one step back for a second to say, what is metabolic disease? What does that represent? And sometimes it's easy to categorize it merely as obesity, being overweight by some measure, getting on a scale. But it's actually quite a complicated condition. It's an inflammatory condition. That's a chronic condition. And many of the factors that you just described, environmental, diet, exercise, and so forth, drives this state of inflammation that can last for a lifetime. And once a cycle of inflammation is started, it is very, very difficult to break. For example, you use the term food desert, you might even call it more of a food swamp, because it's not so much that there isn't food there, but that the food that is being marketed and is available is highly obesogenic. That is, it tends to drive this metabolic phenomena. And it's like many conditions, once it starts and has developed, even if the weight is lost, there is this rapid tendency to regain the weight again and enter into this chronic process of gain and loss of weight. So these social and economic factors that you pointed to, and this really perfect outlining of them, they ultimately result in this chronic inflammatory state that leads to this weight gain.
Very good, thank you. I wonder too, because we hear a lot of research, and we hear a lot of numbers and studies, and Congressman Conaway, thank you for joining us. They know all about you. I gave you a bio before you got here, so they know how. They stayed? Yeah, they stayed. They want to hear from you. So thank you for joining us. We know as a member of Congress, sometimes you're just back and forth. But thank you. Thank you. I'm going to do this question, my second question. When you're looking at these different effects or different barometers, right, and measures, when you're talking about the community, what preventative measures can be taken at the community and policy levels to address obesity and metabolic disorders in communities? Give me a few examples. Dr. Conway, you ready to jump in here?
Well, I'm turning this thing on.
There you go.
This is already on. You mentioned steps that can be taken to address metabolic syndrome in communities. Well, form and structure create outcomes. If our communities are not ones that will encourage physical activity, if they're not arranged in a way that people are able to walk to work, walk to the grocery store, if they're not adequate recreational resources for children to play outside, and by the way, interact with each other, which is a very important thing to do, then that is going to play itself out in chronic conditions that will impact the risk of acquiring conditions such as diabetes and indeed hypertension, high blood pressure, and other conditions which are going to be detrimental to health over the long term. So how we organize our society, what we do in the school systems to make sure that physical education and physical exercise is both part of the educational curriculum and then reinforced by activities in the school, and then carrying on into the after-school space, very important. And so it's a question of planning and understanding the interplay between form, function, and outcome.
Dr. Theodore, you have it?
Yeah, I might, sort of building on top of that, say that it requires sort of listening and understanding before implementation. And what you often find connecting with community health workers and community members is that incredible ideas are coming directly out of the community. How to organize around physical activity and taking walks and coming together as groups to learn how to cook. And all of these things are in the community. And it's really a question of listening to what the options and opportunities are that are present for addressing the issues of metabolic disease, and then kind of reinforcing and implementing them. So I think a big part is often, as opposed to taking kind of an outside-in perspective, where if you eat this and you run this distance and you have your blood pressure checked and so forth, all of which are critical, but starting off by understanding what are the current resources and what are the trusted voices in the community.
Okay.
And I think additionally, I'll add making sure that individuals understand the importance. So beyond those recommendations that you just noted, we can encourage the usage of these community resources and supports, if folks understand the importance of it and connecting it to those factors that are downstream. So, why is there an emphasis on physical activity? Why is there an emphasis on that hypertension screening? Because of the risks that it can mitigate for folks down in their future, down the line. So I think making sure that as we bring folks to the table and are in communication with them, equipping them to utilize the resources to help with their health, if they understand the importance, they understand what may be at risk, and then understanding as well on the provider end or the resource end, what else do they need? What are they missing? What are the challenges? What still needs to be done? How can we provide more resources to the community to help address these factors? I think all of that in the interplay can help us best utilize what's available. Again, just want to stress the importance of it too, knowing that resources will be less moving forward. So it's all the more important to make sure that we know what the community needs and support and lift up those organizations that are really on the ground doing that important work.
As we talk about the various studies in literature and resources, I wonder, what does the current research say about the biological, environmental, and social factors that contribute to higher prevalence of metabolic disorders among non-Hispanic Black adults? Because we're talking about Black adults, okay? All those combinations, we hear the research, we hear the numbers, what else? I feel like we had information, but we still continue to have these chronic diseases that will affect our community. What else do we need to do to make sure how to reinforce the information that's out there in the research? What do we do next?
Maybe I'll jump in to start. So, you outlined some of the core factors, but I would add on top of that often patients are facing highly biased healthcare systems as well. Mm-hmm. And, I sometimes give as a metaphor or as a sort of a story to maybe bring this to life. Often, a patient comes in to see a physician, has a blood pressure that's sort of borderline, and if they're African American, there's a sort of what we sometimes call treatment inertia, which means there's a tendency not to treat and expect, well, maybe this is kind of near normal for this patient, we'll see what happens over time. And so there's a built-in tendency often to undertreat and underscreen patients for disease. And so one of the factors I think is quite important is the presence of bias in healthcare. You heard Dr. Blackstock talk about the lack of Black and African American physicians. We've talked about the lack of cultural competency, if you will, in kind of healthcare systems. And often that culminates in the experience that patients have in healthcare system that ultimately lead to poor management of metabolic syndrome and poorly addressing the preventive measures that you spoke to.
This question of bias in healthcare is something that if you have been, come through the American educational system and gone on to medical school and went into practice, I can remember two things during my training which I carry with me to this now 30 years later. We're having a lecture about pulmonary disease and pulmonary problem in a young, I think this might have been Hispanic male, not yet 30. And we were going over the various ways to diagnose and to treat this condition and sort of asked the practical question, how are we going to make sure that the patient's aware of this and get the treatments that they need? And the professor said, well, not everybody has the same desire, or I think, how did he put it, has the same feeling about their life that you have. And I remember taking him to task on this because, people want to live unless you have a terribly debilitating condition, racked in pain. Most people want to live out their life. The other incident that occurred was a woman who came in, an elderly Black woman, who came into the hospital with chest pain. And, I was probably a second-year medical student at the time. And she ended up dying in the hospital. Now, she had an aortic dissection, a dangerous condition, but the dithering around that occurred on getting this uninsured woman care, she should have lived, or she should have certainly had a chance to survive that episode. And she didn't get it. And I don't believe that would have happened if she were, certainly if she were insured, and it wouldn't have happened if she were, in my opinion, an uninsured white woman. And so you see these things. I've been fortunate to be in government for a very long time at the state level, passed laws to deal with questions of training of physicians on cultural competency and making sure that's a requirement for licensure in the state of New Jersey, and to make sure those CMEs were done. And certainly other things such as the navigators and community support people to help that of the community can go and speak to people where they are and bring the kind of education that can change the course of one's life. We know that educating people, giving them information, will allow them to reorder their steps in a way that will inure to their health. And so these questions are very important. The social stresses that we don't need to go over in detail here because everybody understands those, but stress is very debilitating over the long term to your life and health. It leads to sort of often inappropriate food choices to deal with stress. The other coping mechanisms that people sometimes behaviors that are not particularly healthy to deal with stress, to get relief from stress. Those things have great impact. Food insecurity, financial insecurity, housing insecurity, all those life stressors, safety in your community. The impact of those things in combination can have a very detrimental impact on the health status of people, lack of insurance, which is related obviously to economic insecurity. And we're unfortunately seeing all of this return in droves. We saw people get better, have better health status through the pandemic. The pandemic didn't get you, but at least you had health care. Medicaid was maintained. All of the various hurdles placed in front of people to maintain themselves and Medicaid were removed during that. And now that's when those came off, we saw a decline. And now we're going to see through these really disastrous cuts, if they go through in the way they are, a lot of people are going to get hurt. A lot of people are not going to have a hospital there to treat them. A lot of people are going to go without care. Chronic conditions need persistent and a durable access to primary care and the advice and ongoing monitoring that will help people live and manage their chronic conditions. That's going to be, a lot of that for a lot of people are going to be jeopardized by this disastrous budget that's being brought forth by the government today.
I have a follow-up question for you. How can innovative solutions be leveraged to combat obesity and metabolic disorders? We talk about the general practices. Do you have any innovative practices in mind that you would suggest or that you recommend that we take a look at? Not we, but to research that could help.
Well, I mean, we have a number of medications now that actually work to manage and reduce the impact of obesity on individuals that will change the course of their life. People that have diabetes, if they lose enough weight, their diabetes will go away, and all the attendant issues that come that are derived from persistently high levels of glucose circulating in the body, and all the attendant vascular damage that causes. That goes away when your diabetes is essentially cured through weight loss. So the question, of course, is access to those medications. And this is not just people who are economically stressed, but right on up through people who are, in the middle class, solidly in the middle class, whose insurance plans don't cover the use of these medications that have been shown to work. And so it is right back down to a non-surgical treatment that works. And the question is, in New Jersey, our Department of Health set aside, I think, $2 million to bring this coverage to the Medicaid program. It was something that was done at the departmental level. This wasn't statute that we passed there. But that will deliver a great deal of benefit to the many people that can benefit from losing weight and needing help to do that. I've treated patients with this. I've talked to people about it. The number of times they've gone on diets, they've started an exercise program, they've tried various available things to them to try to lose weight, they have failed. If you're able to stay on these medications, you will lose weight. And you will change the course of your health status doing that. So it's going to be access to what we know that works in dealing with the economic barriers that will prevent people from accessing these life-saving medications.
Dr. Schaefer, can you add to that?
I agree, and I think adding on to that, and I don't want to sound like, I'm repeating myself, but it really is so important that so many of the factors that are most pivotal for this are at risk. So we just talked about the importance of these medications and access to the medications, even for those that have insurance and coverage. We also just noted the importance of primary care and preventative screenings. If someone then has less access or they're kicked off of their insurance, they're at risk then of not getting those screenings. On top of the impact of socioeconomic factors more broadly. So I just think it's really important, again, to think about what we can embed within the community to help fill the gaps. So one example that came to my mind when I was walking through the health fair earlier this afternoon when I passed the Choose Healthy Life table. I know somebody personally that did not find out that they were pre-diabetic until they did a screening at their church from Choose Healthy Life. So that's an example where, regardless of insurance, there was a way for somebody to get that data that they needed for their health care. There was the understanding, the clear breakdown of what these numbers meant, what's the impact, what are the next steps that you can take with resources available for that, that can help bridge those gaps. So I think, again, shoring up our community resources, the patient navigators, and other organizations that are on the ground is really going to be pivotal for making sure that folks are aware of the risks and also are getting the care and the information that they need to help make the best decisions for themselves moving forward.
If I could just add to that, is that a key component of innovation, and if numbers are your jam, innovation is a bit of our jam, is to engage in clinical research where we understand and we can evaluate those risks and benefits, and as you pointed out, Dr. Conway, so perfectly, the economic impact of the use of these agents and these drugs. And so we've taken as a perspective that research should be highly inclusive, and that the individuals that enroll in those clinical trials should mimic the population that eventually can and will use these same agents and these same innovations. So we take the clinical research as an important step in the direction towards creating an environment where innovative solutions are available to all by ensuring that there's adequate levels of inclusion in those phases of clinical research before we start to commercialize drugs.
I have a follow-up question. Thank you for talking about clinical trials. How can the community, right, strengthen and ensure that individuals are learning the right measures or the right strategies for themselves? There's been a lot of suggestions on dieting or medicines, but each community is different, right? There may be a problem with access, right? Or there may be a problem with just having the knowledge on how to cut back or whatever you want to call it. How important is community engagement?
I mean, it's critical. I mean, we live in an era of a lack of trust in all kinds of institutions, in healthcare, in the government, you name it, there is a lack of trust. And it's the community-based organizations that can help us bridge these barriers in trust. So, for example, we have connected with advocacy groups like the American Diabetes Association that works at the local level with locally trusted voices in order to bridge some of that skepticism that exists there. So I think the issue you bring up is the only answer to both understand the solutions and ultimately move towards implementation that will address metabolic diseases.
Okay. I have one sort of final question I want to ask you all to answer it for me. And Dr. Conaway, I'll start with you. What is the one thing you want everyone here to leave with, knowing and understanding about obesity and metabolic disorders in the Black community? One thing, one parting word that you think is very important that individuals can, I mean, there's a lot of things I know, but the one thing that you want to leave it in their head.
I'll start because I have to dash out to my next event, but I would say, first, let me say on the clinical trials, it's absolutely critical that the originators of these medications continue to understand how important it is to have, and I've done clinical trials on obesity and using these medications, proposed medications. One of the reasons I was able to do that is my office is located in an area where I have access to a diverse population. They understand, the pharmaceuticals companies understand that they need to have appropriate numbers of persons of color in these trials because, of course, they're selling these medications to the broad populations. One of the reasons why they're often in Brazil, because Brazil has got a very diverse population. You have original Americans or indigenous people there. You have Black Africans who are brought there. You have Europeans there. And so they can get in one country with a reasonably available access to health care, a population that can be representative of the various ethnic groups that will need this medication. And moving on from that, I would just say this, that diabetes and rather obesity is a treatable condition that needs to be managed over the long term, just like diabetes, hypertension, cardiovascular disease. It needs the aware, the enlightened and engaged healthcare system, certainly at the primary care level, but at the specialty level as well. And you see more people entering in the specialty of obesity medicine and care, but it can be overcome. And we have to marshal the resources in our society to take on the challenge of obesity because we know that it is so impactful on the lives of some increased rates of cancer, increased rates of musculoskeletal and arthritic conditions, increased risk for diabetes, increased risk for cardiovascular disease. All of these are attendant problems. And probably also even neurologic disease as well. And so, as we understand the microbiome and everything else, but the point is, obesity can be overcome. We have the knowledge of how to do it. We just have to marshal those resources and make sure that everybody who needs these resources to be brought to bear on the condition is able to take advantage of them, to actually get them and to use them.
I have worked in the past and in spaces heard researchers speak about these things as if they're inherent to the Black community. That is not the case. These are aspects that can change. We have the control to utilize our resources, use our skill set, the knowledge of everyone in this room to share with our respective communities when we go back to our spaces and organizations to help spread the word of what can be done, what behavioral changes can be done to help mitigate the risks of obesity and metabolic disorders. So don't ever let anyone tell you that these are things that are just baked into, the biology or the being or the culture of Black America. That is not true.
Thank you.
That's perfectly put. It's this is not inevitable, and as we've talked a little bit about today, the answers exist. There's metabolic disease in some ways is complicated at a basic science level, but often the implementation science and what needs to be done to prevent metabolic disease is pretty straightforward. The answers exist in the community. So community-based partnerships and being willing to invest time, energy, money into those community-based partnerships is the answer to overcoming metabolic disease broadly. And lastly, just to leave each of you just with one sort of thought, as individuals, online at the American Heart Association, there is a risk score called the Prevent Risk Score. So you can Google AHA Prevent Score. You can put your own numbers in, and we'll give you a little bit of a sense of your own risk of cardiovascular disease and metabolic disease. And sometimes it helps us as individuals to be engaged in our own health and well-being so that we can show up for those around us.
Thank you. That went by so fast. That's the conclusion of our panel. I hope that you found it very informative. Thank you all for your comments and your strategies and your tips on it. And thank you, Genentech, for sponsoring this panel. It's been great. I don't think we have any time for a question or... No? Okay. Thank you very much. Thank you.